Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam, a cardiologist from Houston, Texas. The feature presentation today is renal hypertension, renovascular or renal hypertension, and we're going to look at various aspects related to renal hypertension in terms of its definition, causes, presentations, symptoms, medical treatment, surgical treatment or stents, risk factor modifications, and prognosis. So let us begin with the feature. Let us begin with the feature presentation. What is renal hypertension? Renal hypertension is something where a person has hypertension due to some cause related to the kidneys. It may be related to the atherosclerotic plaque in the renal artery reducing the blood supply to the kidney. It may be related to parenchymal disease in the kidney tissue itself. It may be related to polycystic kidney, or it may be related to chronic kidney disease from various risk factors. Whatever the cause may be, that increases the renin production in the kidneys that leads to systolic and diastolic hypertension. That's the definition for renal hypertension. What are some of the most common causes for causes for renal hypertension? Okay, before we get into the causes of renal hypertension, I want to spend a few minutes and talk about the renin-angiotensin aldosterone system, or RAS as it is called. In this presentation, I'm going to talk about the renin-angiotensin aldosterone system, or RAS, which is primarily responsible for majority of the hypertension and in most cases of renal hypertension. In order to understand this, we have to look at all the different organs that are involved in the production of chemicals that increase the systolic vascular resistance and thus increase the systolic and diastolic blood pressure. So there is angiotensinogen, which is a polypeptide which is produced by the liver. Then we have a kidney which has the juxtaglomerular apparatus, this green substance here between the afferent and efferent arterioles, that acts like pressure sensors which can detect a decrease in blood supply and then release the prorenin in the form of renin, which acts upon angiotensinogen from the liver and converts that into angiotensin 1. This angiotensin 1 is converted in the liver and also predominantly in the lungs by angiotensin converting enzyme inhibitor into angiotensin 2. Angiotensin 2 is one of the most potent vasoconstrictors available in the body. It does a lot of harm to the body. Let's look at some of the aspects of angiotensin 2. Angiotensin 2 acts on the vascular smooth muscles throughout the body, causing severe vasoconstriction, leading to increased systemic vascular resistance, hypertension, both systolic and diastolic. Angiotensin also stimulates the hypothalamus and the pituitary to produce the antidiuretic hormone, which leads to water retention. Simultaneously, angiotensin 2 also acts on the adrenal glands and increases the secretion of aldosterone, which is a mineralocorticoid that increases the reabsorption of sodium and water. So what is happening here? With a slight decrease in the glomerular pressure, either due to hypotension, anemia, or due to renal artery stenosis and reduced perfusion pressure, the juxtaglomerular apparatus produces renin from prorenin. From there, the renin leads to a cascading of effects producing angiotensin 2, which is the worst possible vasoconstrictor in the body, leading to vasoconstriction, increased volume and salt retention, and also increased water retention. So, what are the most common causes of renal artery hypertension? Atherosclerotic plaques blocking the arteries, thus reducing the glomerular perfusion pressure, is one of the most common causes. In younger population, we may see fibromuscular dystrophy, which can account for renal artery stenosis leading to renal hypertension. The other risk factors, of course, are very familiar to you, that can lead to atherosclerotic plaque buildup in the renal arteries, just as they would in the coronary arteries or in the medium-sized arteries like the carotid artery or the femoral or the popliteal arteries. And these risk factors are, of course, diabetes, aging, coronary artery disease, hypertension, hyperlipidemia, obesity, and smoking. So you have a whole lot of things to address if you have renal hypertension and you want to bring your blood pressure down. It is just not a question of renal hypertension. It is a systemic disease. It is a conglomeration of the end result of multiple risk factors acting upon the kidneys, the arteries, resulting in renal hypertension. In addition to the effects which we already talked about, the angiotensin II on the adrenal cortex, pituitary gland producing ADH, it also acts on the cardiac structure and vascular hypertrophy. It leads to left ventricular hypertrophy and also leads to vascular hypertrophy or muscular hypertrophy of the arteries, leading to systemic vasoconstriction. And I talked about increased thirst and increased blood volume as a result of salt and water retention. Okay, let's talk a word about renin inhibitor. As I said, renin is primarily produced by the juxtaglomerular apparatus, which is located at the afferent arterioles going into the glomerulus, as I showed you in the previous slide. That renin is the one which acts on angiotensin that is produced in the liver to convert it into angiotensin 1. That is, it acts on angiotensinogen and converts that into angiotensin 1. The renin inhibitors block the action of angiotensinogen conversion into angiotensin 1, and that's prevent any further cascading effect leading to angiotensin 2, which is the most potent vasoconstrictor, as I have mentioned it several times. Okay, let's move on to some of the clinical features that may be related to renal or renovascular hypertension. Most patients may not have any symptoms whatsoever. Some of them may have headaches, dizziness, persistent blood pressure which is not responding to 2, 3, or 4 medications, blurred vision, eventual renal damage, elevated plasma renin levels, and of course volume overload due to salt and water retention. All of this which we are familiar with. Let's move on to what are the options available to treat these patients with renovascular hypertension or renal hypertension. First, we identified what are the things that are going wrong in patients with renovascular or renal hypertension. There is elevated renin level. So the ERNIs, direct renin inhibitors, angiotensin renin inhibitors can block the function of renin and thus act at the renin level. Then we have angiotensin converting enzyme inhibitors, or ACE inhibitors as they are commonly called, which can block the action of angiotensin converting enzyme at the level of angiotensin 1 to angiotensin 2 conversion, thus prevent the formation of angiotensin 2. However, the ACE inhibitors also have bradykinin release, which can cause dry cough, which most of you are familiar with, especially in the lungs. And since this angiotensin converting enzymes inhibitors work in the lungs, that's where the problem arises. The third group of drugs are, of course, the angiotensin receptor blockers, which block the angiotensin 2 from acting on the receptors on the vascular smooth muscles, causing vasoconstriction. Thus, angiotensin receptor blockers literally block the action of angiotensin 2 on the vascular smooth muscle, thus reducing the systemic vascular resistance, reducing the systolic and diastolic blood pressure. But since these patients also have a tendency to retain salt and water, addition of a diuretic may perhaps help these patients with renovascular hypertension. A word of caution: the patient should not be dehydrated when we start these patients on ACE or ARBs, because that can lead to worsening of renal function. So the patients have to be euvolemic. Their volume has to be normal before they are started on ACE or ARB medications. Let's look at some of the important drugs in these three major categories, namely renin inhibitors, aleskerin, which interferes with the first rate limiting step in the synthesis of angiotensin 1 from angiotensinogen. So this renin inhibitor blocks the conversion of angiotensinogen to angiotensin 1. So that's where it works. ACE inhibitors, of course, prevent the conversion of angiotensin 1 to angiotensin 2, and here are the drugs. I would say when you are treating hypertension, you cannot master every drug available for hypertension. There must be like 60, 70 drugs. I would stick to 2 drugs in each categories, like ACE inhibitors, 2, ARBs, 2, aldosterone antagonists, there are only 2. So I would say stick to, like most places, they use lisinopril or enalapril. So those are some of the most commonly used drugs, and most of the institutions use these drugs, or stick to the drug that your institution uses, and in that way you are in compliance with your employer. Well, that's besides the point. Angiotensin receptor antagonists, we have like candesartan, irbesartan, losartan, and valsartan. These block the binding of angiotensin 2 to the vascular smooth muscle receptors, thus reducing vasoconstriction and improving the systolic and diastolic blood pressure. Aldosterone antagonists, of course, block the action of aldosterone and thus reduce the effects of aldosterone in terms of retaining salt, water, and potassium. So those are some of the effects of these 3 classes of drugs that are available. As I said, we could use a small dose of diuretics, but we really need to monitor their kidney function and volume status. Let's move on. Here is a chart that has a very detailed explanation of what are the drugs available in the ACE and ARB and ARNI groups, the starting dose and the maximum dose, and how good these drugs are. I would say, I would stick to lisinopril and perhaps enalapril, and it's your choice. Whatever your institution is using, you need to stick to that and see. In that way, you know how to adjust the dosages, how you can add other drugs in combination with these drugs when you're treating patients with renal hypertension. The goal is to bring the blood pressure down with medical treatment. Let me re-emphasize this again. The goal is to bring the blood pressure down using medical treatment. And here are the ARBs and ARNIs. There's only one ARNI that's available right now, and that is the sacubitril valsartan combination. Anyway, candesartan, and it gives a maximum dose that you can use, like losartan maximum is 150 milligrams once daily, valsartan 160 milligrams. There are other ones which are also available, like talmosartan, which can be used also. Okay, so keep these things in mind, and there are a number of clinical references that are available supporting these drugs in the management of renal or renovascular hypertension. And here is a complete list, composite list of all these drugs. And you may want to print this and put it on your notice board so that you know what drugs to use if you are dealing with a patient with renovascular or renal hypertension. And when do we do interventions? Let's say you do an ultrasound of the renal arteries and you find maybe significant 80-90% stenosis of the renal arteries, and due to ocular reflux, you're tempted to go ahead and put a stent in that stenotic renal artery. And what are the indications and how good are the stents in improving the patient's blood pressure, improving the patient's quality of life, or improving patient's longevity? These are very important questions which we are going to see if we can find some answers. The only class A indication for renal artery revascularization is a patient with heart failure, with recurrent unexplained heart failure or sudden unexplained pulmonary edema, and if they have high elevated renin levels, and if there is evidence for renal artery stenosis, then that is a class 1 indication for performing renal artery stenting or surgery. Whereas all the other ones are class 2B or class 2A, and this is like you have a malignant hypertension which is accelerated and is not responding to multiple drugs. That may be, and again, the level of evidence is kind of not so strong. If someone has unstable angina with significant renal artery stenosis and continued chest pain, it may be a class 2A indication for performing renal intervention with stenting. Okay, how do we place a stent in the renal arteries? If we can look at this, we have the right renal artery and the left renal artery. There is atherosclerotic plaque, which is blocking 80% of the lumen. Then a stent is placed in this blocked segment, thus improving the renal blood flow, improving the glomerular filtration pressure. That is the key, which improves the renal flow and thus bring down the renin level. That is the theoretical hope. And here is a mechanical aspect of how a stent is placed. We put a guide wire here, put a catheter right into the ostium of the renal artery. Then a guide wire is passed. Over the guide wire, a balloon mounted stent is placed in the blocked situation. Stent is expanded, which leads to opening of the artery. The results look great. The blood flow looks excellent, but the question, do the patients do better if they have a stenting compared to people who are treated just medically? That is a $1 million question, which let's see if we can find answer to that question. Okay, here is an example of a renal artery bifurcation stenosis. This is like you have a stenosis at the bifurcation of the two branches. In fact, they had to put a main stent in one of the bigger arteries, then come back and put probably a kissing stent in the second branch, but nonetheless, the results look exceedingly good. Angiographically, these images look excellent. You would think the renal blood flow should be reestablished, bringing down the renin level, and their blood pressure should be controlled, hopefully without any medications. Is that true? We don't know. We'll find out. And here are landmark trials in renal artery stenosis. Patients who underwent intervention, like from 1998, 98, 2000, 2009, 9, 14, 2017, there were several different studies done for renal artery stenosis in different parts of the world, but the overall composite result is not that impressive. It's not that helpful. It's not that, for example, here, 1998, no difference in blood pressure in angioplasty group at 6 months versus the control group. No difference in decrease in creatinine clearance after 24 months. No difference in kidney outcomes, blood pressure, CV events after 34 months. In 2000 and 2015-17 ACC/AHA renal artery stenosis guidelines, medical management is recommended. Let me underscore that one. In 2017, the ACC/AHA came up with the guidelines that patients with renal hypertension or renal artery stenosis should be medically managed unless they have worsening clinical conditions like the class 1 indication which I talked about in patients with heart failure who are having recurrent uncontrolled blood pressure, or patients with unstable angina with renal artery stenosis who are like class 2A indication. But generally speaking, the results have not been promising. And here is one study showing such results that was published in 2013 in the American Heart Association Journal. At the end of 40 months, there was no significant difference between the medically treated group versus those who received stent plus medical treatment. So, ladies and gentlemen, there is the answer to your $1 million question. What do we do? What is the prognosis? Well, so we know what is the underlying pathophysiology. We know what causes renal hypertension or renovascular hypertension. For most of the time, we need to be dealing with the risk factors to reduce coronary atherosclerosis. Number 2, we need to be reducing weight, controlling blood sugar, and also controlling blood pressure with medications. Reducing risk factors is of paramount importance in trying to reduce your risk of further kidney damage. To sum it up, ladies and gentlemen, I have covered extensively the renin-angiotensin-aldosterone system or RAS system and the drugs that work, the 3 classes of drugs, namely ACE inhibitors, ARBs, ERNIs, along with small dose of diuretics. Remember, I underscore the word small dose of diuretics because you don't want to volume deplete these patients because these drugs don't work well in volume depleted patients. So, ladies and gentlemen, thank you so much for watching this presentation. I hope this has been educational and useful to you. And please do subscribe to our YouTube channel. We have more than 250 presentations on cardiology topics. If you want me to prepare a presentation on any other topic, basic science topic, to explain things properly, the mechanisms, please do leave the word or two in the comments. I will certainly do a research and make this presentation. In fact, I was asked by one of the subscribers to do a presentation on renal hypertension. That was yesterday. I spent all day yesterday, and this morning I was able to put the presentation together and recorded this. Thank you so much for asking me to make this presentation, and I hope this will be educational to you. Please do subscribe to our YouTube channel, and I will see you in the next presentation. I am Dr. Nik Nikam from Houston, Texas.